Hello and welcome to Health Matters on Channels Television. Thank you so much for joining us. I am Mary Alale Yusuf. This week we look at cleft lip and cleft palate, which are openings or splits in the upper lip, the roof of the mouth, called the palate, or both. Cleft lip and cleft palate are consequences of incomplete closures in facial structures of a developing unborn child. These can occur as isolated events or associated with inherited genetic conditions. Cleft lip and palate make their appearance less than desirable, but can be corrected by surgery with minimal scarring. My guests are, joining us virtually, a consultant orthodontist and Dean of the Faculty of Dental Sciences, Lagos University Teaching Hospital and College of Medicine, Dr. Oluranti Da Costa. And in the studio, a consultant maxillofacial surgeon and senior lecturer, Lagos University Teaching Hospital and College of Medicine, Dr. Olawale Adamson. You're welcome to the show, both of you. Thanks for joining us. Let's start off immediately, and I'll ask you, Dr. Adamson, we know that the closures are not complete. It's been established, you know. And if somebody's lip is split, that can easily be seen. Yes. But why are these closures not complete? What's missing? What happened to the child that such a thing, you know, took place?
Well, what took place actually is what we call the intrauterine. That is while the mother was pregnant with the baby. Because usually the baby's face is formed in the first trimester of pregnancy. So during that time, whenever there's a disturbance, you have the face not being fully formed. Okay. So yeah, that was happened there.
But there's no particular reason, like maybe one gene is missing or one chromosome is half formed or anything like that?
There are two types of clefts, actually. We have the syndromics. Those are the ones that are associated with other things in the body. Okay. And the isolated ones are not syndromic ones. But for the non-syndromic ones, are the commonest ones that we see around, it's been noted that there's an interplay between the genes and the environment. Some genes have been identified specifically associated with the cleft, while it's been noted that there are some environmental factors, like talk of the mother taking folic acid during pregnancy.
Ah, that folic acid.
Yes, very important.
Okay.
Talk of mother smoking or taking alcohol in the first trimester. Okay. So those are environmental factors.
So that's why they're so strict about taking alcohol.
Yes, very, very strict. Okay. Alcohol, smoking, and folic acid intake.
Let me ask Dr. Da Costa. Dr. Da Costa, when the lip is not split, because it says either or, it could be a split lip, a split palate, or both. When the lip is not split and the palate is split, how is it discovered? Because, you know, the child comes that way and, you know, it cannot talk. How is it discovered?
If at birth the child undergoes thorough examination, it should include the mouth. And if it does include the mouth, then it would be noticed at birth. But you will actually find out that in some cases, the less fortunate parents or the less fortunate patients may not discover this until later on, sometimes as late as when the child starts talking, and then you notice that something is wrong somehow. And then they suddenly notice they open the mouth. Or when the child is feeding, if a child has a cleft palate, they have problems with feeding in that the food goes in through the mouth and a lot of it comes out through the nose. That is enough to tell you that there's something wrong somewhere. When the child is sucking or fails to be able to suck properly, then your attention should be called to what's going on with the mouth.
Thank you. So, Dr. Adamson, what other problems, apart from not being able to retain the food, what goes in, you know, pours out, what other problems does this child have?
Okay, well, yeah, the first one, like you said, is they're not being able to retain the food, but the other problems that as the child grows along, others are like ear infections, like because of the way the palate is, it affects the ears, the eardrums, so they have ear infections. They also have speech problems. When it's noted that some sounds can be made by the patients with cleft palates.
I see. So which is more important to forming sounds?
Yes.
The lip or the palate?
Both.
Okay.
But the palate is necessary to make most of the sounds. Once the palate is not there, some children, you notice that they talk as if the voice is being produced from their nose.
Okay.
Call them hypernasal. They can't make normal sound like every other person does. Also, there are other problems, so like repeated infections because of the food coming from their nose. Also, their dental, their teeth are scattered in a way.
Okay.
You know, so, and also social, psychosocial problems, like because of the way their lips are and the way they talk.
Oh, yes.
They're
that
usually
could affect the
yes,
child's
it
mind.
does. It does. Most times they're usually withdrawn. They're not like social. They are usually very quiet or abused by some people. You know, so that really affects them.
That could be bad. So I was wondering, you know, Dr. Adamson, I was wondering why just the upper lip? So I remember that some people have a cleft chin. Yes. Is that a defect as well?
Well, I wouldn't want to call it a defect.
People like it.
Yeah. There are some variations in the body that our bodies are not the same. Doesn't mean it's a problem. The lower lip, it forms very, very early in life and very fast. So it's very, very rare to have a cleft of that lower lip. So it's the upper lip that is most susceptible to having clefts.
Are there any risk factors to developing this condition? That's to you, Dr. Da Costa, Professor Da Costa, I mean. Are there any risk factors?
In terms of the development of cleft lip and palate? Well, yes. One of the risk factors is the genetics. If a patient has a history of cleft lip and palate in the family, it increases the likelihood of them having a cleft themselves. That doesn't necessarily mean that they will get it, but it does increase the likelihood as vis-a-vis somebody who is in a family that doesn't have it running in the family. And of course, all the other environmental factors that have been spoken about by Dr. Adamson are also risk factors in their own way. Exposure to radiation, lack of folic acid, excessive cortisol levels, taking up anti-epileptic drugs, all these end up increasing the likelihood of it occurring. And then another risk factor is elderly pregnancy. The older you are, the more likely that kind of problem may come up. And it's not only the age factor in females, it's also the age factor in the men. So the men don't get to escape this time.
Escape this one as they escaped others. So let me ask you further, Professor Da Costa. We've heard about ear infections, you know, that could result from this cleft lip and palate. But let's assume there's somebody who has this condition and it was not attended to and the person has grown. Are there any other complications that could result?
Growth. Growth is a major problem in terms of cleft lip and palate. People get to adulthood and they actually do not have it treated. They go through all the repeated ear infection. They have poor speech, and it also affects the growth of the upper jaw, most especially. So the effects on a patient with cleft lip and palate are dental, skeletal, and occlusal, as well as the socioeconomic, the psychosocial, and things like ear infections. If it's syndromic, then they may have other issues like syndactyly, that is fusion of the limbs. They may have heart conditions and other things going on in other parts of the body.
Okay, thank you. That is bad, though.
Yeah.
At what age, Dr. Adamson, is surgery advised? When do you advise that they bring a baby for surgery? Because I know it's done in infancy, right?
Yeah, but, well, usually we prefer the patients to be brought in immediately they were born. First, for counseling for the mothers about how to feed the babies and how to take care of the babies. Then we stage surgeries, because if the child has a lip, it can be done in 3 months. But if he has a palate, it can be done when the child is about a year old. And also there are other surgeries that we do for the babies, for the children. Like if they have a speech problem after the palate repair, there's a speech surgery we can do for them when they're about 3-4 years.
So you keep doing surgeries
yes.
till the child grows up?
Not only surgeries alone, treatment, it's actually like a long-term treatment for the child.
Okay.
Where you have a surgery for the lip, surgery for the palate, then you do like a speech therapy. That's to teach them how to talk all over again. Also, like they go through orthodontists like Prof. Da Costa to arrange the teeth, make it better. And if needs be, there are also secondary surgeries that can be done, like speech surgeries, like alveolar bone graft. So
that's a whole load of surgeries.
It's a whole lot. Yeah, it's a whole lot.
Okay, so between 0 and 3 months, how do you feed a child who has this problem?
Oh, well, we usually train the mother, especially those that have the palate only.
Because the child can't suck so well anyway.
Yeah, for the ones with lip, they could suck. But it's the ones with palate that have issues with sucking. So we usually advise the mothers to like raise the head of the child almost upright and to feed the child with like a long spoon to the back of the mouth. And feed oftenly, but slowly. You know, and so the child, once they do that, the child is better.
I'm gaining a very healthy respect for my palate at this point. Dr. Da Costa, can you tell us what time do you like best for such a person to visit you? And what is the job of the orthodontist in this case?
Thank you very much, Mary. Now, the best time to see the patients is within the first few days of birth.
For the orthodontist?
Yes. And I know this will come as a surprise to many people because they feel that we don't really come in until there are plenty of teeth in the mouth. But no, right from birth, we have our own role to play. We do have some patients that have very, very wide clefts of the lip and of the alveolus, which is the tooth-bearing portion of the jaws, of the upper jaw. And what we try and do is make that particular gap a lot smaller, because by doing this, we actually help to improve the success rate of the surgical repair, which takes place, as Dr. Adamson has said, between the ages of 3 months and 6 months of age. So we start using an appliance. We can start, in some cases, using an appliance to reduce the width of the cleft.
Do you know where the teeth are going to pop out from? And do you do something with, you know, I don't know what they call them, wherever the teeth are going to pop out from? Is that an issue?
Of course, but we don't worry about it at that stage because the teeth are just developing. But a lot of the time the teeth do pop out on either side of the cleft, and some of them do actually fall into the cleft line itself. But we deal with them as they turn up. There's a specific area that the cleft normally develops. So we know the teeth that we have in that area, and we deal with them accordingly.
Okay, let's go for a very short break. When we come back, we continue talking about these teeth, the clefts of the palate and the lip. Please stay with us. Welcome back. We're talking about the repair of cleft lip and palate. This is Health Matters on Channels Television. Today, we're going to be corresponding by email and Twitter. moalale@channelstv.com. That's for the email. And for Twitter, at CTV_Mary A. You should be seeing those on your screen to ask about questions of cleft lip and palate. Dr. Adamson is in the house, and Professor Da Costa is with us via Zoom. And I'm going to ask her immediately, how long are you going to be friends with this person who has cleft lip and palate? How many years is this person going to keep visiting you?
I think the orthodontist probably has the longest duration with the relating to the cleft patients, in that we will probably see the patients right from birth, and we'll see them through till as long as 18 years. if they continue. And then we have particular peak areas that we expect to be very active in our treatment of the patients.
Okay, so I saw one of the visuals that we have, you know, the patient actually has a tooth there that is bent, as if it is soft, as if it is malleable. I don't know how that is possible. What do you do to make these teeth come out properly?
Well, are we dealing with the child on the screen? Because that's a newborn and there's no
this is not this child on the screen. There's a 12-year-old with a bent out tooth.
Yes, rotations, very common in cleft patients. It's very common for us to have rotations around the cleft areas, teeth in the region of the cleft. And that's what braces are all about. Bent teeth are very common in cleft patients, and they're not unusual in patients that are normal. And that's where braces do their work. And the use of braces is normal. It's considered standard in highly developed countries. Management of the cleft patient is teamwork. It's not a job for just one person. And the patient comes to us at that age. If you're talking about the 12-year-old that you mentioned, at 12 years old, the patient will undergo comprehensive orthodontic treatment. That means they're likely to have to wear braces on both the upper and the lower teeth in order to straighten everything out.
Okay. Dr. Adamson, do you sometimes have to do something with the jaw of the patient? Does it shift in any way?
Yes, it does. We've noticed that with the cleft palate, when they grow, the upper jaw doesn't grow as much as the lower jaw. So they have this slanting face, which they want to bring out. So we sometimes could, with the orthodontics, like I said, we work like a team, help to expand the upper jaw and sometimes bring it forward also.
At what age?
Well, depends. There's one we do when the child is about 7, 8, and there's one we do when the child is about 17 years, 18 years.
Because I imagine that after all these surgeries have been done, the child's jaw is still growing. So how do you handle that growth?
Well, the growth of the jaw usually by 17 years for boys are stopped, and by 15, 16 years for girls are stopped. So we usually wait for like 17, 18 years to do any jaw advancement procedure, definitive one. But meantime, we can do a minor adjustment to the jaw, like use the child's growth potential to expand the jaw. And that's also quite safe.
All right. So this child, usually, in fact, all the pictures I've seen, it's like when the cleft is a complete cleft and goes all the way to the nose, so the nose is disfigured. Is that also part of your job?
Yes.
Do you fix the nose like some sort of cosmetic surgery?
Definitely.
Make it more symmetrical? I can't imagine a daughter having that kind of nose and one nostril smaller than the other nostril and bent, you know, sideways and all that.
Part of the surgery that we do, it's called the rhinoplasty also. We actually repair the nose also, cosmetically, make them equal, both nostrils. And we've had some patients before that by the time we are done with them, they're like, no more, you can't know anything happened to them like a cleft. They've had all surgeries.
What does the ear, nose, and throat doctor do?
Yeah, no, I mentioned earlier that they have ear infections. So the ENT doctors, the ear, nose, and throat doctors, they come and check the ear for infection. And during the palate repair, there's a tube we usually put in some of their ears to help with to prevent the infection. They put that tube in there. So they are also part of the team that we need.
The tube prevents infection?
Yeah.
How?
Because the problem with cleft patients is that when there is a cleft, the ear is meant to drain fluids out. It doesn't drain. So they're putting a tube to help that drainage. And therefore, that prevents infection from occurring there.
So water will be...
No, normally, in everybody, your ears is connected to your throat. And when you talk of
yes. I get it. The drain is internal. It goes into the throat.
Your throat, yeah. So that's why sometimes you take some medicines or let you take air drops. You can feel it in your mouth sometimes, because there's a connection between the ears and the throat. That's in normal people. But in people without clefts, that drainage is distorted. So the ENT surgeons come in and they put in a tube to create another pathway for that connection to be patent.
Wow, that's a lot. Professor Da Costa, we are talking about an infant here. He's having, or she's having, repair of the lip, repair of the palate, some sort of dental appliance to expand the roof of the mouth and all that. How do you ensure that the child doesn't just put his hand in there and rip everything out? Because that's what children do. They just, anything that is disturbing them, they rip it out.
Well, that has happened.
It has happened. There you go.
In fact, yes, severally, in fact. Sometimes when you have children that are not ready to cooperate, you're just waiting for them to get a little bit older. I have had children that I've had to just leave and say, you know what, come back to me when you're ready. I just tell the parents, look, let's not fight this. We put in 3 appliances and they've managed to damage all of them. Let's not fight this. Let's just wait. And you'll be surprised that when they become more conscious of what is happening in their mouth and the appearance of their teeth and their face, they become very, very cooperative as they get older. I've had quite a number of patients that have done just that. They didn't cooperate because they didn't appreciate what it was about, but when they get a little bit older, then they cooperate. But I have to admit that the majority of my patients are very cooperative.
That is great to hear. Okay, so this question goes to both of you. I want to ask, in all, first of all, how many surgeries are we talking about? For this, I'm pitying this little child who has to have braces done, teeth straightened, palate repaired, and all that. How many years do you have to do this? And also, I want to ask, does it really disappear, all those sutures you put in? The pictures I see, the person always looks a bit different, not quite like somebody who didn't have those problems. Do we have somebody who looks very normal at the end of the day? Let's go with you first, Dr. Adamson.
The surgeries that we do, it depends. Like if it's the lip, just one surgery for the child is fine. And if it's the palate, sometimes some children have just the palate alone.
Okay.
And one surgery for the child is fine.
Okay.
So it usually depends on.
So minor cases, maybe 2 surgeries.
Yeah, maybe 2 surgeries, and maybe 3 surgeries. Right. And when you talk of the scar, usually after every surgery, there's a scar after every surgery. We expect the scar to get better with age. So usually for the children, for the lip, when we do them, we're not eager to assess them then. We wait till they're much older. And for some of them, I've had some that had no sign of surgery in their body. Like I said, we've actually started about 7 or so patients completely that they're fine. Now when they talk, you can never know
you can't detect that there ever was a speech problem.
Yeah, never. They went to therapy, they went to surgeries, and they had surgery. Everything was just perfect. So there are some like that are clear perfect. But some, 1 or 2 minor issues. But we can always correct if there's a need for that.
Okay, Professor Da Costa, that question has been answered, but I have another one for you. We've heard about teeth growing on top of each other for these children. You know, what they call them, extra teeth, and then in some cases, no teeth at all. How do you handle that?
In terms of extra teeth, it's easy. You just take out the extra ones if they're in the way. Dealing with less teeth than there should be, then we have 2 options. Either we try and close up the space that's been left by the missing teeth, if the teeth are not many, maybe just 1, possibly 2, or we can create enough space to put in artificial teeth. And in that case, we'll probably start, if the child is young, we'll start with something like a regular denture, and then going up, we can, when they get to adulthood, we can now use implants.
The permanent one.
To replace the teeth. Yes, they are permanent. Implants or bridges, both of them are permanent replacements.
Okay, so that's it for the show today. Thank you so much, Professor Oluronti Da Costa, all the way from VI, consultant orthodontist, and Dr. Adamson.
Thank you very much.
In the studio with me, consultant maxillofacial surgeon. Great to have you both on the show.
Thank you very much.
Thank you also back at home for watching. I am Mary Alale Yusuf. Have a wonderful day.